And good afternoon, everyone. I want to welcome all of those who have joined us this afternoon. I'm glad there are so many participants today. So I would like to go right to introducing Anne Landry, Nathalie Dubois, and Mireille Gaudreau, who will be presenting today. It has been a real pleasure to work with them over the past 3 years on this project. I'm invited, and you. They have been very dedicated and passionate about this high-quality project. So I think their presentation will be very interesting. And Nathalie and Mireille work with the Montreal Public Health Department, which is part of the Integrated Health and Social Services Center in South Central Montreal. This center includes 10 centers and provides services for the public there. The Quebec program for breast cancer screening comes under the Montreal Public Health Department. Nathalie is the coordinator, and Mireille coordinated the implementation of the project. Nathalie is a researcher in health policy and services, in evaluation and complex programs. Nathalie has conducted research in the area of the project. Anne Landry is a planning program and research officer who was the regional director of promotion for the Montreal breast cancer screening program. She was also responsible for the multiplier networks component of the project. So, without further delay, I will ask Anne Landry to begin the presentation. Thank you. Good afternoon, Anne. Thank you. I would like to talk a little bit about how this will roll out. I will be talking about the project, target groups and objectives, the activities, the 3 parts that we conducted. Then Nathalie will review the results, and Mireille will talk about the lessons learned. We will have a period for questions and discussion afterwards. So, to introduce the subject, for those that might not know, the Quebec Breast Cancer Screening Program, it is a program that comes under the Quebec Health and Social Services Department. It was introduced in 1998 and is aimed at reducing the number of deaths caused by breast cancer. So the project came under an existing program, but we realized that it wasn't all women that we were able to reach, even though all women between the ages of 50 and 69, were eligible every 2 years, and they received a referral letter which allowed them to make an appointment for a mammogram in a designated screening center. So, to give you a bit of context, in Montreal, we met with the various organizations to see why the participation rate was lower than the Quebec average. And what we realized was that the women who were least likely to get screening were those who were from cultural communities, who were isolated and disadvantaged, low levels of literacy, and older women. So those factors were, among other things, a lack of knowledge, unfamiliarity with the program and its benefits, difficulty understanding the tools, fear and poor care experiences. They perhaps hadn't been welcomed properly or dealt with nicely, and so they didn't go back. And finally, difficulty accessing someone who can validate the information. Now, there's a map that you can see on the screen that shows that there is quite a different response and participation rate depending on the area of Montreal. In some areas, there was low participation. For example, La Montagne, you see 35.6%. These are people, women mainly from Asia, so 38.5%. And so these women did not participate in high numbers. And then the next slide here shows the factors associated with non-participation. There were these various reasons, including the socioeconomic criteria I mentioned. We've got a lot of information here, and the two main factors were low literacy levels, so often recent immigrants or women that were living in poverty. And the second factor was language and cultural familiarity, knowledge about breast screening, and also certain cultural, perhaps, resistance. I think that this shows the factors, the leaders in the community and our organizations helped identify 4 groups, 4 cultural communities that we wanted to work with in particular. We applied for funding in January 2011, and obviously we applied to the Canadian Public Health Agency for funding. This came under the Quebec program because, as you saw, the participation rate actually varied quite a bit on the island of Montreal. We wanted to increase the participation, especially among those with low literacy levels and who did not participate for other reasons. For example, women who didn't speak either English or French, women over the age of 60, women who are socioeconomically disadvantaged, low levels of education, and women from the Haitian, Arab, Chinese, and South Asian communities. So why those 4 communities? Because those are the main immigrant communities in Montreal with women over the age of 50, and they were groups where the participation level was low. So this project is a multi-strategic project. We wanted to look at, take an approach that had several parts so that we could use a number of strategies to try to increase participation. So the first part was a social marketing campaign throughout Montreal. Second, we sent written reminders and had targeted follow-up. And third, we had a multiplying network supported by sponsors. And we, of course, had an evaluation team that had the difficult job of evaluating the results.
The social marketing campaign was based around 3 acts. The ideas of understanding, acting, and supporting. Those were the messages conveyed. First, we wanted women to understand what the information we sent them was about. So we had to adapt our information about breast cancer screening with mammograms and participation in the PQ-DCS. Then we wanted them to act, to make it easier for women to take action, be that making an appointment, get information, and get to where they need to go to get their mammogram. We also wanted them to do all that while being supported. We wanted to provide resources that will support their decision, making available phone numbers, hotlines, and the various community organizations that were around to support those women. So we wanted them to assist. We wanted to assist them and translate all these promotional tools so that they were better able to understand everything. So the team met with a variety of partners to identify what key elements we needed in our project. First, we wanted to make sure that our referral letter was a medical prescription signed by a doctor. It wasn't merely a simple letter. They didn't need to go back to see their doctor. We sent them a ready-made letter that they could take directly to the mammogram clinic. We also spoke to radiology clinics that were affiliated to the program, and we wanted to make sure that we're recognized for the quality of the services they provided, and they were recognized as such by the department. A lot of women didn't know that screening mammograms were entirely free in Quebec. And you can, if you look at they had the RAMQ, so the public insurance card, but women didn't understand that their mammograms were free and they thought they had to pay to get them. There was also a key medical message that was a screening mammogram is the most effective way of detecting early-stage breast cancer, which increases the chances of recovery. Also, that mammogram results were sent directly to the family doctor. Women were concerned because they didn't know that their results would go directly there, that there would be intermediates. They were worried that their family doctor wouldn't follow up on the mammogram results. So we had to tell them that, yes, they would be followed by their family doctor. And we also, another key message was that screening mammograms are done when a woman doesn't have breast problems. Some women said, I don't have any problems with my breasts, so I don't need a mammogram. And we were trying to convey the message that, no, they're done when you don't have any problems, and it was important. And another element for women from cultural communities, they were saying that all the radiologists that were conducting the mammograms were women. Some women from those communities were afraid that it would be men doing those tests, but we reassured them and said that they're usually women. So here's an example of the letter that we sent out under the program. We tried to do this as visually as possible, so that even a woman who doesn't understand French or English very clearly would see that there is a prescription right on the letter, so they would understand where this is coming from. And on the back of the letter, there wasn't anything before, so we added pictograms and graphics with a little bit of text, translated as simply as possible because we wanted the words to be as easy to understand as possible, and with an image that made it crystal clear what the words were getting at, so that they did go and get that mammogram in Montreal. And we also offered another measure to make it easier for women to understand. We focus grouped all of this so that women who have low levels of literacy in English and French, who come from ethnic communities, cultural communities, what we got from all those focus groups is that they wanted neutral and easy to go to illustrations, soothing colors to minimize anxiety, and minimal written information with no more than 2 or 3 key messages. You have here the gamut of tools associated with this project. You also have the list sent by mail of all those clinics they can go, and we'll see a bit later the various posters and pictograms that we prepared for the cultural communities, not only for Francophone Quebec women, but also women of all these communities. We translated all of these documents and adapted them. Now the website. It was redesigned. There's 2 parts to our website. There's a general public portion for Montreal women aged 50 to 69 likely to use the web. And we also have another section more geared towards health professionals who are involved in promoting the PQDCS and PQDCS partners. So the website was translated into 5 languages, French, English, and 5 languages in this program. So Haitian Creole, Punjabi, Urdu, Mandarin, and Arabic. So at the very top, you see the change language options when they wanted to select the language. The banner was also adapted to target the particular the cultural community. And the Centre des Femmes de Saint Laurent, so the Mont Saint Laurent, City of Saint Laurent Women's Center helped with all this. When you click on your language of choice, you also would see the regional contact information and the phone number and the multilingual hotlines that all of the organizations had set up. These were hotlines where people answered the phone in the language of the caller. And we also have a georeferencing tool that would allow women to input their postal code to see where the closest clinic was. Following that, there was the second component of the project. So the written reminder and the targeted follow-up. there were 68,000 women who didn't respond. We had sent an original letter to them, but they hadn't gotten their mammograms. So along with the Canadian Cancer Society, we sent another letter to them, to those 68,000 women who didn't respond. And the Canadian Cancer Society took a small sample of these women in the districts with high poverty rates and low literacy levels, and we called them to ask them a few questions in order to help them with their decision to get a mammogram done. And that telephone reminder took place about 15 days after the letter was originally sent. And the third portion was the multiplying network. What we wanted to do with this network was to reach out to women in their own environments with interventions adapted to meet their needs, to give them information that was easy to understand, simple and available, translated into different languages, and finally to create a network with culturally and linguistically sensitive settings and credible individuals. We had originally modeled our multiplying network. There's a small error. There weren't 4 sponsors, but 3 sponsors. We should have had 4 originally, but we had to reduce that number to 3 along the way. What we wanted to do was to create this network with peer educators in all of these areas where we find the women that we needed to target, shopping malls, places of worship, and each community had their own multiplying network with key information providers, peer educators, and partners. I'm not going to name each one of the sponsors, but each sponsor had a host organization and a partner. You had the Chinese Family Service Organization, you had the Haitian House Organization, you had the Women's Center, as well as the South Asian Women's Community Center. And these organizations were of great help because they were very well established in those communities. They were very credible, they were well known, and it gave these women sponsors the opportunity to work directly with them. And it also allowed us to set up phone lines in which those women calling from different cultural communities could speak in their own language. And this is the main hotline number. I could spend hours explaining these adapted and translated tools because they were validated by focus groups from cultural communities. We had to find the right people to show. We had to translate it properly and adapt each poster for the cultural communities. And we also had these little flyers prepared for the peer educators coming from a variety of backgrounds, Haitian hairdressers, Indian teachers, and we wanted the peer educators to see these aide-memoirs, if you will, when they were in the various centers that they frequented. We also had a profound integration with the community media, radio stations, and newspapers in different languages. We have a whole slew of them in Montreal and on Montreal airwaves, and it helped us tremendously to pass along the message. We also wanted to disseminate this information in all sorts of places frequented by women, shops serving them, places of worship, halal butcher shops, and we also set up kiosks in places where the community gets together, where it be festivals, concerts, and what have you. I'm going to give you some information, very quick information, for each one of our communities. Slide 34 deals with the Chinese community. In Montreal, there's about 50,000 Chinese people in Quebec, mostly located in Montreal and Brossard, which is a suburb of Montreal. There are neighborhoods that have high concentrations of Chinese people. Jeanne-Mance, which is the Chinese neighborhood of Chinatown. There's also the city of Verdun, Saint Laurent, and LaSalle. The thing that's important to remember about the Chinese community is that they have several oral languages, but they had only one written language, which allowed us to use that single written language in newspaper ads, the community's newspapers, and it could be used across the spectrum of the Chinese population in Montreal. Obviously, we set up partnerships with a neighborhood organization that helped us organize workshops and presentations to reach women. And if we hadn't had our sponsor from the community, we would have never known that there is associations that aren't really visible, organizations that aren't visible, but are based on regions of origin. We really worked hard on organizing conferences with these various associations. We also approached the businesses visited by women, whether it be convenience stores, Asian supermarkets. We targeted those quite heavily. And what you have to remember about the Chinese community is the importance they give to family and education. So going to Chinese schools Sunday morning with all these Chinese grandmothers who take their little grandchildren to learn Chinese, that was also an important area to target. And finally, we also did workshops in churches and various religious institutions. And what we noticed when working with the sponsor from the Chinese community, when it was the nurse or myself giving the workshops, it was important to learn a few words in a language to facilitate contact, even if it was just hello, how are you? And there was also another issue that we needed to discuss, the issue of prevention with Chinese women. Now, moving on to the Haitian community. The Haitian community has a very old immigration that dates back to hundreds of years in Montreal. Some statistics, the community is very organized because it has such a rich and long immigration history. The Haitian community is very spiritual, and we found a good number of multiplying agents in churches, pastors, and priests, and what have you. Oral communication is very important in Creole, so we did interviews in Creole language on community radio stations. And the place of women and families is very important. It's called potomitan in Haitian, and we had unexpected partnership with a textile factory where you find many of these Haitian women that allow them to have mammograms to accompany these women at the textile factory and to set it up in their dining halls, for example, during lunchtime. And something else is also important to remember is that there's a lot of health professionals in the community, and the recruitment of volunteer physicians and nurses was very easy, and it helped tremendously in promoting the need for the work that we were doing.
And we also found that it was easy to provide the information at different times, use flexible and accommodating schedules. And okay, I'll just quickly tell you that the Arabic-speaking community has one common language, Arabic. And there again, we try to target places of worship. There are people who are learning French and looking for work, and we try to target those places as well. It's a complex community. Now, talking about South Asian women, there are, again, places of worship, gurdwaras, and other places. We needed to deal with a number of different languages, and there, of course, the place of worship that I mentioned, and religious education. We have to take into account that the notion of prevention is different, and if you look very quickly at this, you can still see the different approaches that we've taken. Now I would like to introduce Nathalie, who will talk about the evaluation aspect of this project. Good afternoon. My name is Nathalie Dubois. I will present the evaluation and the evaluation methodology. So this was a major endeavor to evaluate this project because it was a very complex project. There were three main parts that stand on their own, but they also are integrated. The targeted populations were very diverse, as has been pointed out, and there were also multiple partners that were involved in planning and implementing this project, and there were many environments and contexts where the work was done. There were 4 objectives for the evaluation. First of all, to account for the project implementation process, check if the project, as planned, matched its implementation. Third, measure the short-term effects of the intervention. The approaches mixed theoretical and methodological steps, and the study was mostly qualitative but integrates also a substantial quantitative component. The evaluation was conducted between January 2013 and August 2015. It used self-administered questionnaires, one-time and recurrent, interviews with individuals and groups, administrative data banks, and administrative and financial documents. The information sources were the coordinators, stakeholders, sponsors, partners, peer educators, the women, and the experts. It was an iterative analysis, mainly, so that we could check the data collection sources. Before presenting the results, I want to review the evaluation questions that were used. The first was, were changes made to the project between the time it was submitted for funding and when it first started? The second question, were the resources actually invested in the project the same as the ones that had been planned? Third, was project governance maintained? Fourth, were activities and services implemented as outlined in the initial work plan for this project? And finally, we wanted to check what segment of the population the project reached. So I will just very quickly review the results now. The first, so were changes made to the project between the time it was submitted for funding and when it was started? So this is very important. There were 3 major things that happened. First of all, there was a reduction in the financial contribution from the public health agency, and that meant that the planners were not able to implement the project the same way. The proposed strategies were maintained, and investment in the evaluation component was 6% of the budget. So despite the fact that the funding was reduced, we still were able to maintain those proposed strategies and maintain this aspect of the budget, that is the 6% for evaluation. The agency provided additional funding for the evaluation so that we were able to do this work as the project went on. The second question, were the resources actually invested in the project the same as the ones that had been planned? In fact, no, because more resources from the Public Health Department were invested than initially planned. The Public Health Agency's resources were used only for managing the project. But resources were recruited thanks to the PHAC funding. We had a team of 3 sponsors and a project manager that were trained. And finally, the partners, including the sponsors, played a very important role and participated actively. Third question, was project governance maintained as it was proposed? In fact, we see that there were significant changes that were made to the governance structure. There were improvements that the project administrator wanted, and the team manager played a stronger role. And this helped us mobilize the activities of the outside partners and make the best use possible of the information that we had. The major question about the activities and services being implemented as they were outlined, number 4, overall, we can say that with few exceptions, all activities included in the work plan were carried out. There were certain adjustments that were made to the deadlines, but always with the consent of the public health agency. So very few activities were not carried out, in fact. A number of activities were actually added to the work plan. There were meetings with the partners, there were videos and so on that we hadn't planned on. And now I want to talk about the overall evaluation, but I want to talk about certain key points in particular. So we'll start with the social marketing campaign. If we compare what was planned with what was actually done, we can see that in the communications plan, there were things that had an impact on the project. We had proposed 3 major events. There were high expectations for local activities. We had planned for 54, and we in fact had over 1,000 activities of all types. About 140 activities dealt with the information being provided. The communication tools were used out in the field, and we can see that in different languages and different cultural communities we use these different tools. As for the special follow-up of slide 58, we developed tools. We worked with our main partner, and we used the referral letter, the written and telephone reminders, and we found that the special follow-up component tried to reach 4 groups. We also had a group that just received the initial material, so that was the group that we could compare the others with, and so we had the control group, and then we had people who received only the letter. For example, the first group received just the letter, the second group received the letter and a telephone follow-up, and the third, the letter and another mail follow-up.
You see on that table the number of people that we sent the letter to, but what's important to know is that we were able to hit the targets we had set for ourselves, meaning we wanted to hit the largest population of people with a reminder. 95% got we wanted 95% to receive the letter reminder, and then a smaller percentage a reminder by phone, but we hit about 40%. When I say 40%, it means that we reached by telephone 40% of the targeted women, but unfortunately the intervention was only done fully with 2.60%, which means that the questionnaire was completed in full with only that number of people. We deployed tremendous efforts to reach people in low-income neighborhoods. But I'll leave it to you to look at the table. Now, in terms of the multiplying network, we developed a larger number of activities than what the project originally called for. You don't see it on the slide, but you have all of the media activities that were proposed and that targeted very specific media that were important for the targeted populations. For the multiplying network, we also sent out a larger number of than what we expected of peer educators. We had 30 to 40, and we trained actually 214. And these peer educators were on the ground, convincing women and promoting their health needs. And considering the time I have left, I'm going to move on directly to slide 62, where we talk about the segments of the population that the project reached. As Anne said earlier, the project targeted 3 different types of women. First of all, you see the triangle on the screen. The larger one is a group of eligible women with low literacy levels. Then you had the women who did not respond for at least 2 years. And finally, new immigrant women from the 4 cultural communities. Did we actually reach those women? Well, in the case of the first group at slide 63, you see it's difficult to be more precise in our estimates, but when we see the communication tools that were used, the media activities, and the website, the efforts put into the PQDCS website, we can only assume that we reached that targeted clientele. As for the women who did not respond, we had a very low number of returned letters, and we can only assume that we only have to call about a smaller number of that larger population. And as for recent women, you had the local activities and training conducted. We reprinted the referral letters, and that was very important because we were able, through the sponsors in the community organizations, to ask for the reprinting of 103 letters. That allowed those women to get a mammogram. Of course, there's the whole accompaniment to designated screen centers. 109 women were accompanied by sponsors to their mammograms. And of course, there's a number of peer educators that were trained. We cannot ignore other populations reached that should not be neglected. Family members, husbands, children, slightly younger women, and targeted women, and all the rest. The obstacles and the numbers and enablers that we encountered were vast. I can't go in detail into all of them, but there's about 6 of them. First of all, one barrier, the issue that we had with the project definition, the structure and application of the program on the ground, the human resources, the partners in the field, the practical aspects, and the technical aspects of the project. I'm going to move directly to the evaluation of the effects because I don't have that much time left. We had 3 major evaluation questions about the measurement of effects. First of all, did the project have the desired effects? Did the project produce unexpected results? And what factors can explain the results that we observed? The first effect we wanted to have is that women use the referral letter. I think we can be very proud of the results we obtained in this regard. You have to remember here that the women that were targeted by the project were women who did not respond to the letter, who had not responded to perhaps a first invitation in 2007 or to the most recent invitations and referrals. And that means that despite it all, according to our 4 groups, you had the control group, letter only, letter and phone referral, and the last one. Women who used the letter only to get a mammogram represented more than 50%, and in some cases more than 60%. If you compare it to the special relaunch project of 2007, the percentage was more around 34%. So we can be doubly proud of our results this time around. The second change we wanted to see implemented was the use of the multilingual phone line. Contrary to what we thought, throughout the planification, it was not possible to create a second phone line where we could have really observed the results that the multilingual phone line had. However, when we look at the activity on the CCSR phone line, we see a real increase in the number of calls received, both by the clientele than other calls, including the voicemail box. We saw a 12% increase, which is significant. It's not a net result, but there's a gross effect that we cannot ignore. We also wanted, as a result, to increase the participation in the PQDCS by type of contact. The participation rates, we thought there'd be a larger difference depending on the means that we used. The control group presented a 13.6%, whereas the other effects were around 9.2% for a total average of 12.6%. There might be a bias in terms of the phone line, contrary to what we had hoped and anticipated. The calls were shorter. When you see at the time that was spent on each phone call, it's less than 9 seconds. It could be a lesser tool in the evaluation of the effects of this project. I'm going to go now to slide 72 to remind you that overall the participation rate in the PQDCS in Montreal is 49.3%, whereas the average across Quebec is 58.0%. So there's a lower participation in Montreal than on the whole of the province taken into account. However, when you look at the increase and that curve, the whole of Quebec has a sort of a staggered increase, whereas Montreal has a more swooping curve, which coincides actually with the two periods of awareness campaigns that we conducted. Let's move on to 75. What I'd like you to notice when you look at the rate of participation in the PQDCS according to the various barriers in the population, we realize that the participation rate for women who are in the lower income situation or low literacy level was higher than the other groups, but it nevertheless remains in line with the general trend. However, what we can notice is that the rates that correspond to the relaunch periods there might have been a slight increase in those populations outside of the low-income, low-literacy level populations because of the very efforts we were deploying with this project. Now, again, these are not net effects. These are gross effects, and we can only calculate what we've calculated starting in 2007 and the efforts that were launched then. Did this project have unexpected results now? Yes, naturally. We hit some targets that we hadn't clearly defined in the original drafting of the project. First of all, there was development of organizational and personal knowledge and skills related to the issues in question. We also improved practices for the DSP and its partners, whether it be in the development and integration of several adapted tools, whether it be improved knowledge and skills, or the sharing and transfer of the knowledge produced. We also saw that there was a mass investment in factors that support and bolster women's use of screening mammograms. We saw tangible results in the focus groups, especially when women started to talk to us about their increased knowledge of the PQDCS and their changed attitudes and intentions, which were more positive than before. Now, what factors could explain the results observed? There's a good many of them, but I'm going to limit myself to the most significant ones. First of all, it was the quality of the defined and planned project. Then the expertise, the commitment, and stability of the project team within the organization. You can't forget that the DSP relied on its DSP team, but also hired a bunch of people who supported them in the development of the project. But for the PQDCS team, there was a net contribution to it all. Then we had the financial and human resources invested in the project, the trust, credibility, and openness of the parties involved. There was also the consensus regarding the relevance and the significance of this project, and, of course, the knowledge of and sensitivity to a cultural community. The fact that we had sponsors that came from those communities that we're targeting was essential. Now, the project was implemented as defined, but required greater investment by the DSP than originally anticipated. Then, we retained that the project had various effects on individuals and professionals, on organizations and mammogram screening services offered, on improved practice with new immigrants with poor literacy levels. It also had effects on the network, local and community partners, the environment that the women lived in, as well as the population targeted and as a whole. There's, of course, some important issues to consider in all this. First of all, that this project can be organized in all sorts of organizations, in this case the DSP and the various partners. There's an important investment by the individual. You have to take into account the expertise, skills, values, and motivations of the various stakeholders. There's the whole partnership aspect of this, the dynamics, the interests, and the history that peppered the launch of this program, and everything that has to do with the context and the environment. You cannot put aside that the PQDCS led to a reconfiguration of the project and that there was a redrawing of the various regions that were targeted by this program, taking into account cultural and ethnic realities. And finally, there's a target population to consider, which had an immigration status. These were all recent immigrants. They had language, culture, religion as varying elements, and low literacy. And now, after I've said all this, I will pass the mic on to Mireille so that she finishes up our presentation.
Good afternoon, everyone. I'm pleased to join you. A number of aspects have already been broached by my two colleagues, so I just want to talk about the kind of macroscopic view as the project manager. Now, I've been dealing with the project for over 3 years, and I want to deal with this very generally. First of all, the targets and interventions, point A. B, project management and process, and C, what we learned about the implementation, continuation, and transfer. To begin with, then, the lessons learned with respect to targets and interventions, we really needed to deal with the existing interventions, but also to work in new areas as well. In our initial project plan, we were not sure we were going to have focus groups, and in fact that they were very important to the success of the project. They gave us exceptional feedback to help us really understand. So we reinvested money in that aspect that was supposed to be used for other purposes, and that was a very good choice. We started with the idea that we would try to use traditional media like radio, but also less conventional media, websites and so on, and social media. And we found that women aged 50 to 69 were indeed using Facebook for their family and so on. So it seemed that this was a good complementary way of reaching these women. At the end of each slide, I have what went well, what didn't go so well. So something that was very good was that we hired sponsors from the targeted communities, and it was hard to do at first, but this was a very important factor, and without it, we would not have been able to implement the project. We also used outside specialists to lead focus groups. We had a literacy specialist who helped us a great deal with the project. Now, what should be done differently if we were to start over? We did have a lot of partnerships with organizations. There were service agreements to conclude and so on, and we spent a great deal of time and energy on that. We dealt with an outside communications firm that had materials, and we spent a lot of time on that. We also needed to think about a strategy to update and adjust the information and to make the connection among all of the groups and media. Now I'm on slide 81. What did we learn about project management and process? We learned a great deal as a team. It's a large interdisciplinary team that included professionals, doctors, nurses, an information officer, administrators. So we had a lot of people involved. We had to work together, obviously, but we needed to learn to work in a large team and with people from other cultural communities. And so every week we spent at least 3 hours together in meetings to work together, to think about the values, how we could show respect, and even as a manager, I had to adapt the way I worked with people from different cultural communities. At the beginning, my role wasn't even taken into account, but I spent a minimum of 1 day a week, generally speaking, on the project during the busy periods, and so it required more of my time than was expected, and I think everyone found that they were putting a great deal of effort into it. It was really a project that belonged to everybody that was involved. So it demanded a lot of flexibility from all the partners to adapt the various activities. We had to find volunteers. We had to get people to set up the tents and do all sorts of things. Often this was outside our working hours or with resources we really didn't have. Now, what went well? We hadn't counted on working with outside resources, and that's something we might do differently. We might use internal resources for social marketing, for example. We have to take into account all of the requirements when it came to color and so on. So there were many adjustments to make in the products that we were using and the tools. Another point I would make is that the internal financial resources might be used instead to oversee the budget because we were using a separate organization. And that meant that there was a different budgeting process used. We were very flexible, and we were able to free up an officer to deal with this. But we want people to be able to participate in the project within the scope of their work. And finally, with respect to implementation, continuation, and transfer, we invested a great deal of effort to ensure that all deliveries were met. We put a lot of time into documenting our activities. We had logs, we had reports to ensure continuation and to be able to share the tools with other regions in Quebec and other groups. Something that changed the project a great deal was the impact of Bill 10, which was adopted in 2014 in Quebec. The bill abolished the regional agencies and the health and social service centers There were budget cuts and centralization, and that meant we lost about 30% of the money that would have been received for the project. People had to leave the project, and our partners within the health network had hoped to work with us to expand and regionalize the project, but it is a whole new reality now following the adoption of that bill. We had a lot of people who came and went because of cuts, because of absenteeism. We had transfer activities happening during the project. We had 3 different regions using the template referral letter and so on. So we did have some interest from other groups. When we started, we had the health and social service centers working with us to try to have continuity processes to help with these particular communities. So we were working with the managers, with nurses, and so on. And so we created these ties, and that's a very positive thing. What could we have done differently? Well, we could have defined and endorsed more formal continuity processes because we need to continue what was already started. If we have 3 full-time people and they are no longer involved, then that's a problem. We're working with the other organizations involved to make sure that agreements are signed so that we can continue the work. So it was a large-scale project. It took place over a number of months. We mobilized the internal team and partners and health facilities and community organizations. We had a common goal to act on specific barriers and targets, and positive impacts were felt on the participation of women. We had adapted products, and so I can say that you can find all the information on the website. We had information that is available now in these various languages, and we feel that it is important that we work with so many partners, with the Canadian Public Health Agency, the Canadian Cancer Society, and all of the partners, of course, the Health and Social Service Centers in Montreal. And I can't give all the names, of course. That would take too much time. But without their help, we would not have had the impact that we have had. So thank you very much. Thank you. This is Brigitte again. I want to thank all 3 of our presenters. That was a very interesting presentation, and we realize that you have accomplished a great deal. I want to go directly to questions now. We already have a few. Perhaps the answers could be brief because we only have 15 minutes. Thank you. So please let us know a little bit about how the project will be continued. Mireille touched on this a little bit, but could you give us a little bit more detail? Yes. The project will definitely continue. We will be working with the cultural communities. We have the multiplier network. We have the telephone lines and other tools still in place. But we will have a reduction in the amount of effort being made, but we want to see how we can serve other centers. And we may use the same approach for other health problems like vaccination. Now that the project is integrated into the approach used in Quebec, then we can do this. Thank you. I want to move now to another question.
was the main strategy to send letters to the women or to use the peer educators? Perhaps, in fact, it was a multi-strategic approach, but I will let you answer. Well, certainly the letters were already being sent, and the project wanted to go further. So we sent follow-up letters, and we also had the peer educators. So we had these two sources of information for the women. So we did both. The program already sent out letters, but we expanded that and added these other follow-ups.
I've got another question from Brooke, who's asking if you could say a bit more of the support you got from the Canadian Cancer Society for your project. What was its role? What was its support? Well, in fact, their support was, they have an expertise about how to talk to people about cancer, and their expertise in this project was the phone calls. They were the ones who were conducting the phone calls following the referral letter. They hired two nurses who were taking care of the phone calls, and they also helped us develop the training for all of that, the phone lines and everything else. All right, thank you. Another question from Brooke again was asking whether there's going to be a report about the letter or the whole of the project in English. Well, in fact, all of the information is available in English. As I said in the website, the letters themselves are translated in English, and we're on the verge of finishing up the report, and we're going to send it off to the Public Health Agency of Canada and to Brigitte. Okay, there's a lot of the tools that are available in English. The final report of the project is in French, but if there is a manifest interest in getting highlights from the project, they could certainly be extracted and translated into English in a short summary. Perhaps you could send us that request directly, Brooke, and we can certainly talk about it directly with you. I've got another question from Laurence now, who's asking if I understand exactly, the rate of participation didn't increase as dramatically as hoped, despite all the efforts you launched. The slides weren't very clear on that. Could you clarify that? Yes, we can. Obviously, there was a lot of detail that we didn't give you. You can find them in the report. We unfortunately don't have the time to do it all here, but there is an increase. What we noticed was that there was an increase in the overall participation rate of women to the PQDCS. That is a gross effect. We can't say simply that the project was behind that increase. Our project targeted women who had not responded to the letter and who lived in lower income neighborhoods, who were more stigmatized because they were more recent immigrants, they were isolated, and they were living in difficult socioeconomic conditions. And that is a small portion of the women who usually participate in Quebec's breast cancer screening program. The second thing, or I should say the other thing that we should mention, is that in terms of our intervention, Anne said earlier that there was three large components to our I'm Invited and You project, and each component was they were independent. Each component was independent, but it reached all of the population, either in whole or in part. So there might have been some cross-pollination, if you will. It would be difficult for the evaluation team to isolate which communications means led to an increase that was noticed here. Another thing, when it comes to the phone calls, in the literature, we know that telephone contacts might have a much more major effect on increasing rates of participation than a simple letter. But in our case, we cannot simply assume that the phone call truly led to a increased participation in order to prompt the women to respond to the invitation much more actively. According to the data that we've gathered, the phone calls were much too short to explain it away that way, and it would be difficult to use the phone calls to explain the increased rate. I'm going to stop there because I'm taking up too much time, but I invite you to consult the report in detail because there's some important nuances that explain the increase in the rate of participation of that targeted population. Unfortunately, I'm going to move the microphone to Anne, who wants to add a little something. Go ahead, Anne. Yes, I simply wanted to say about the rate of participation. We saw it a bit earlier. What's important to highlight here is that the increased curve that we saw in that graphic in Quebec is a bit more stagnant and more arrested, whereas the Montreal curve was much more important. There's almost a 3% increase for the city of Montreal. We can certainly say that the project was behind that increase that we didn't see anywhere else in Quebec. Thank you very much. This is Brigitte speaking again. I'm going to take one last question because I believe that we're going to have to give ourselves 1 minute at the very end for a last word. I have a question that is a question from Brandy, having to do specifically with slide 84. She's asking whether you can explain the words, the most effective and safe way to detect breast cancer. It says safest way to detect breast cancer. That's what it says in English. In French, it's the word sûr that's used. Can you explain if it's more certain, that's the translation for the word sûr, if it's a more certain way compared to what other techniques to detect breast cancer? Well, in fact, we were talking about the clinical exam that doctors do in their clinics. We know that there's only the mammogram that allows to detect even the smallest lesions, cancerous lesions in the breast. There is no better way of detecting them. Well, I don't see any more questions showing up. I don't know if you have any feedback, any comments. I'd like to thank the three speakers, of course, but perhaps you have a last word to say before I hand the mic over to Bill. Well, I'd like to say we would have been able to talk about this project for the rest of the afternoon, and unfortunately we couldn't answer all the questions because we had to summarize at a certain point. But this was a 3-year project that had a lot of moving parts, some of which we could not simply include in the project, but you can always email us about it. All right, well, thank you very much. And I have one small question. Could we have this presentation for my colleagues who participated in the phone call project? It's Lynn who's asking this question. I don't know if you agree giving this presentation to them as well. Perhaps we should await the final report and weigh what's in there to make sure that everything is up to snuff before we share it with another group. I'll leave it to you. Yeah, well, you can reach our PQDCS team. We can certainly inform her on whatever she's interested by. We also have another PowerPoint presentation about the various groups across the network, and we can put that up on the website as well. Oh, well, that's very kind of you. Well, once again, thank you tremendously to all three of you, Anne, Nathalie, and Mireille, for your wonderful presentation. And now I'll pass the mic on to Bill. Thank you. Well, thank you, Bridget. This is Bill. I'd simply like to conclude this webinar by once again thanking all our participants for having taken the time. I'd also like to thank our three presenters, Anne, Nathalie, and Mireille, for their very interesting presentation, really excellent. Our moderator, Brigitte, as well. Thank you to her for having watched the clock. It's very important, and of course for having asked the questions that were sent in. I'd also like to thank the planning team that helped put together this webinar, the Public Health Agency of Canada, and the Regional Montreal Public Health Department. And finally, a big thank you to each one of our interpreters. Very well done. And on that, I say thank you once more to all of you, and have a great afternoon.